I'm Giullia Silveira, PGY2 in the Internal Medicine program at Northwestern Medicine McHenry Hospital, and today I'm going to be presenting a rare case of MALS in a young female with POTS. As an introduction, medial arcuate ligament syndrome, also known as celiac artery compression syndrome, is frequently underdiagnosed due to its non-specific symptoms and the lack of awareness among healthcare professionals. Patient symptoms are often misattributed to psychological factors, and psychological evaluations and potentially unnecessary interventions not rarely leads to delayed or misdiagnosis, which prolongs patient suffering. The coexistence of MALS with postural orthostatic tachycardia syndrome or POTS is particularly rare, posing unique diagnostic and management challenges, underscoring the need for increased clinical awareness due to this dual presentation. For our case report, we have a 19-year-old female with previous medical history of migraines who presents to the clinic for an AD follow-up due to positional dizziness. Patient reported orthostatic lightheadedness, most pronounced upon standing, and chronic epigastric pain, which was exacerbated postprandially, with relief upon standing and with positional changes. During initial appointment, patient was vitally stable, with no abnormalities reported on physical exam. Labs were within normal limits, and CTA head and neck done during the ED visit were unremarkable. A week after initial appointment, patient contacts the office again due to worsening abdominal pain, which was now associated with nausea and vomiting. Patient then started presenting with daily syncopal episodes shortly after, often associated with standing. It was suspected that the patient might have been presenting with orthostatic hypotension due to poor PO intake and dehydration from her intractable nausea and vomiting. At that time, patient was re-evaluated in the office. Vitals were stable. She had diffuse abdominal pain on palpation, which was new, worse over the epigastric area. Patient had no dizziness at rest. She was orthostatic positive and tachycardic when standing up, which was also associated with lightheadedness and dizziness. Due to the continuous symptoms and unique characteristics of patient presentation, she underwent CTA of her abdomen and pelvis. The CTA was showing focal narrowing on the proximal celiac artery with estimated stenosis of approximately 50% or slightly greater, which is highlighted with the red arrows. After CTA, patient was then referred to vascular surgery and started on midodrine due to recurrent syncopal episodes and suspicion for associated POTS. US mesenteric Doppler was ordered by vascular surgery, which showed hemodynamically significant velocities of proximal and distal celiac arteries at rest, with significant decrease with deep inspiration. Findings were consistent with compression of the celiac artery. Patient underwent comprehensive evaluation for common causes, including EGD, colonoscopy, CT, abdomen pelvis, gastric emptying study, and HIDA scan, which were unremarkable. The patient was then trialed on conservative measures, including dietary modification and midodrine for presumed POTS, yet she continued to experience syncopal events and debilitating abdominal pain. Patient then underwent a successful laparoscopic division of the median arcuate ligament. Post-operatively, her syncopal episodes resolved completely, epigastric pain subsided, and only occasional, easily managed nausea persisted. Follow-up with Doppler evaluation is planned to assess sustained vessel patency. In discussion, this case underscores the rare overlap between MALS and POTS. MALS was identified in 5% of POTS patients, while approximately 50% of patients with MALS exhibited features of orthostatic tachycardia. MALS is a diagnosis of exclusion and common causes must be ruled out. Confirmatory diagnosis usually is obtained by CTA or MRI. Pathophysiologically, celiac artery compression not only induces splenic ischemia but also affects the celiac plexus, which triggers sympathetic overdrive and neuropathic dysfunction, provoking orthostatic intolerance. Surgical decompression via median arcuate ligament release remains the cornerstone of treatment, with 60 to 80% of patients achieving significant symptom relief. Younger age and classic postprandial presentation predict favorable outcomes. In conclusion, despite advances, the non-specific clinical picture often leads to protracted evaluations and delays in definitive care. Increased reporting of MALS and POTS case, alongside systematic outcomes analysis, is essential to raise clinician awareness, optimize diagnostic and management. Thank you.